the organizing committee here, Dr. Irfan, to the Pakistan Chest Society, Dr. Jawad Ansari, and the entire team of the Pakistan Chest Society, and my fellow colleagues, faculty, trainees, anyone who's here. I really appreciate the opportunity. This is the first time I came for this kind of meeting here, and I'm really interested in trying to promote bronchiectasis, try to establish bridges of collaboration across US and Pakistan. And I really think that things are very advanced in that part of the world, and what it seems like that we are kind of trying to lag some of the work up. But with the resources, I think our country do a whole lot. We have a lot of talent. So excuse me if I bring something up that is not connecting here or whatever, because I just got here and within last 24 hours, and my entire goal is to promote in any capacity I can. Also, I have a talk on CF, and that's what I've been doing for many years over there now. So for any trainees in the audience here or anyone who can dive on these cases, these are some imaging cases of non-CF, and one of the big things we do over is genetics of non-CF bronchiectasis. And as far as I understand, the workup for the non-CF genetic aspects of non-CF bronchiectasis is kind of limited or perhaps lagging in this part of the world. So what I'm trying to promote here is when we see these cases, in the case on the top left here on the CT, with a thick finger and glove kind of appearance with mucus plugs for the trainees, when we look at that, it has certain pattern. And for those people who are familiar with this, this is a CT of ABPA. So there are some findings on the right side, which is kind of telling us somebody with cystic and more advanced bronchiectasis, both sides in the lower lobe, will think about either systemic diseases or something like aspiration. And then on the left side of this, on the second left, is a case of PCD, an adult PCD case. And on the top right, on the bottom right of the slide here, is a case of non-tuberculous mycobacterium. So just give you some flavor of different cases and the imaging characteristics that we see in these patients, and we try to direct the workup. So it is estimated that non-CF is about 500,000 in US. So just to give you a direct correlation, the CF bronchiectasis, which is the other big portion of that part of the world, it's about 35,000 to 40,000 patients. Since 2019, one of the new medication came out for CF called Trikafta, and that medication has really impacted a huge survival benefit. So forever, the survival used to be less than 40 years. But now the median survival with CF has gone up to like 70 years. And the worldwide prevalence of that disease is like 105,000 patients. I was just dropped the other day here in the hotel by someone who's mentioning about infertility. So my prime point is we have to recognize these cases. Infertility is one of the manifestations. He's a young guy with no other symptoms. And CF can just present as infertility. So it may not be directly there. If you're looking for someone will have a born CF with a newborn screen or have a genetics of this and that, it can present in various flavors. So the point here today would be trying to give you some highlights in the next 10 minutes. We keep on. In US, there's about the 8.7% increase per year of this recognition of this disease. Do you know why it could be? So we think it could be like we do more low-dose CT scans over there for screening of lung cancer. So that is one thing that we are recognizing and picking it up more on the CT chest. The other thing could be that these patients have some more workups, more genetic disease workup that the primary care as well as the pulmonologists are able to do. So it's not the message that go out and screen everybody for CF, but look for the presentations, the cases that could have it. So what are those characteristics? Someone who has got like middle ear infections or ear infections could have some correlation with PCD. Someone who has got infertility, GI problems, multi-organ disease, they can have something like CF. Even in the adult patients, they present it. I diagnose about 2 patients over there a month, 1 to 2 a month, who are 50 years old or longer with adult CF. So moving on to the pathogenesis of the non-CF, and this is the famous pathway. So some sort of injury leads to some damage to the epithelium, whether it's immune deficiency on the top right. Is there a pointer I can use? Thank you. So Right here, some sort of immune deficiency or impaired mucociliary clearance of some mechanism like CF or PCD leads to some mucus plugging and buildup in the airways, lead to progressive inflammation, infection, bacterial buildup, leading to some structural distortion and damage. Interestingly, in 2024 in US, we joke about that still, hopefully before I retire in the next 15 years, that I will see that there is less and less of this blue pie and this pie. This is the idiopathic bronchiectasis. So still, in 2024, there's something idiopathic. We don't, despite have all the advancements we have with genetic disease, with all the other workups that we are able to do to recognize whether it's alpha-1 antitrypsin deficiency or it is something like PCD, CF, or acid reflux, and many other pathways that I will share here, there is still about 50% of the patients who are called and thought to be idiopathic. So in this different regions of the world, in US, it seems to be that immune-related is the most common and prevalent bronchiectasis according to this paper and study. But worldwide, idiopathic seems to be a major figure, which is about 50%. I was at CHEST meeting just last year, and I was meeting some colleagues from Bangladesh, and they were there, and they were mentioning that a lot of people with asthma and COPD translate into bronchiectasis. And that may be true here, that you see a lot of advancements in people who are progressive. But it's not clear, like, why not all the people with COPD and asthma develop onto bronchiectasis? Is there certain phenotypes or genotypes within those patients who lead on to develop bronchiectasis? If it would be all, it would be a universal rule that everybody would progressively, and it would be a progressive end stage and advanced bronchiectasis among those patients. In this slide, I'm just trying to, there's a role of microbiology and microbiome. So we look for, if you have Pseudomonas or certain sort of bacteria, it will be that there are treatments like inhaled antibiotic, and we can improve mortality. I mean, we also treat somebody with MRSA with inhaled vancomycin. We also have different Achromobacter, Stenotrophomonas, and these other bacteria that we culture. So one of the big message for the audience and trainees is, please do culture, culture, culture. Do not forget culture. I'm actually on WhatsApp group with many other patients and families, never had a culture. So very important thing, like I'm sure that esteemed colleagues here, they do it. Maybe it's part of the run and the volume of the patient or within the flow of the clinic. I would like to learn more. What is the microbiology setup? How often do we do culture? But that is very important because it impacts mortality and morbidity. How about the certain viruses? So we have respiratory direct pathogen panel. We do it in these patients. We are able to screen about 20 different viruses. We can also look for COVID, flu, and we have treatments for those. So luckily, that's important. It impacts the progression. And then the fungal, increasingly we look for aspergillus. ABPA or those diseases, can have impact by certain treatment with biologic therapy. On this conference, I have not seen impact of biologics. That's a huge thing for us. Nucala, mepolizumab, and all of those mAbs. I hope that we are able to see it in Pakistan, hopefully soon. Talking to industry across the hall, and my push is, please bring it on. It can impact and change all the asthma outcomes. It can change the bronchiectasis ABPA. So we need to speed it up, ask for those things, look for those things, and it can impact the advancements here. There's a huge increasing concept about neutrophilic and eosinophilic disease. Eosinophilic is something that can be treated with inhaled steroids. Inhaled steroids are going to increase prevalence of non-tuberculous mycobacterium. So as of last year, we are discouraged to use inhaled steroid in someone with bronchiectasis because it promotes the growth of non-tuberculous mycobacterium. So it's very important not to bundle up eosinophilic with neutrophilic. Neutrophilic, yes, there are treatments coming up like brensocatib and also other therapies like nitric oxide or phage therapy. So look for those cultures and then try to treat it. Again, the location of bronchiectasis, as I showed on the CT, just a cartoon that many of us are familiar. If you have lower lobe, something with the blood flow, connective tissue disease, aspiration. If you have in the middle lobe, typically famous like non-tuberculous or Lady Windermere syndrome, and upper lobe like sarcoid, CF, PCD. So just a lot of information on this slide, but I just thought to see where we are in US. So almost many patients undergo CFTR genetic sequencing. And my understanding is that this is currently either limited or not available. So I think first we have to recognize these patients who are eligible for these patients. So for this kind of testing, infertile, difficult to treat asthma, bad sinus or sinus polyp disease, somebody with irritable bowel syndrome, we call them over there, but abdominal symptoms, multi-organ disease. So definitely look for those. We do this for 27 genome sequencing with the NGS analysis. The PCD, it's about $1,000 per patient over there. I don't know cost here, but if we can try to replicate it and try to able to promote this, I think that will be a huge development for us. I'm sure we are missing patients with CF. There has to be patients. My desire is to establish a bronchiectasis and CF and non-CF registry, bundle up with the US registry and Embark registry in Europe. We are behind there. We need to do this work. We have patients. My whole message for this is, for first and very unique conference, and traveling all this to promote that registry development. So I really appreciate collaboration and collegiality. I have international partners who are willing to do this. PCD panel, we also screen for these patients. Again, we have many situs inversus patients who have Cartagener syndrome and these kind of presentations. So genetic analysis is something very important. Lung clearance index, Dr. Usmani was talking about all the resistance, and yesterday in the small airway disease. This is way sensitive to detect small airway disease than large airway disease, like FEV1. FEV1 is a late manifestation. If you want to pick up small airways, FEF 25, 75, and so, this is where we are. Lung clearance index is going to help us out, detect it in the most earliest fashion, the small airway disease outside. So bringing that on in Pakistan will be a great thing. Again, I'm not sure low-dose CT is available, but that is something that we will promote, and I hope we are able to do these things. Something with the COVID, we did a lot of 4 years or so, I have experience in grants that we were able to use in portable devices and home monitoring. So we have dashboard. Patients are doing it at home. We get the data in my office. I look at it and able to monitor it. Not directly. I have respiratory colleague, therapist, and other staff. I've developed a setup of team of people and a mechanism that we have alert set up. If someone has a 10% drop in PFT, we intervene. So that is something that is helpful. We also give them either antibiotics or try to ask if their technique was correct. We can do a Zoom meeting with them. So they are able to do those things within their home. I saw somebody here with a portable device, so I'm not sure the experience, but that will be a great tool to have. Nasal nitric oxide. Many of the pulmonary colleagues are not familiar with that, but very important tool for bronchiectasis. Again, this helps with the PCD. So the two big diseases that can be used, screening for this would be for PCD. A very low level, less than 200 of nasal nitric oxide, is going to be very helpful in ruling out PCD. It is something that we are using in the adult clinic. CF also has low level, but it is higher than PCD. Sputum microbiology, as I emphasized, sweat chloride levels. Sweat chloride done in Pakistan is actually obsolete, unfortunately. I was talking to Dr. Irfan. He was saying that Aakan has some capacity to do the quantitative, but outside of that, I'm not sure how often are we doing it. But the one that is Lahore Health University Pediatric Hospital is doing it is actually conductive technique, which is not used anywhere in the world. So it's very important to bring it up and look for those patients who are eligible. Sweat chloride, according to quantitative technique of more than 60, is diagnostic of CF, is the gold standard for CF diagnosis. The antibody response for immune deficiency or immunoglobulin deficiency will be helpful. We also look for the Aspergillus-specific antibodies. Audience was talking about the ABPA cases yesterday that Dr. Javed was talking about from the grand round. I didn't even see an IgE. So how can you talk about the ABPA without the IgE? So it's important to have these antibodies and then go to the ABPA level, unless you are that smart to do it just on the CT or some other way. Alpha-1, again, we are able to do those and then look for also eosinophilic and neutrophilic, which is where the world is, and the research is really looking at whether it is neutrophilic or eosinophilic. And based on that, treat them whether they inhale steroids or not. We also look for the fluoroscopic esophagogram to look for acid reflux and manometry. I hope the GI colleagues can do anything better than a PPI. That's the only thing that they do, put them on a PPI. We want to see like manometry or some other surgical techniques that we can do, but there are interventions that you can change somebody's life if they have it. And it's very common. It's very common unless you do it. So if you do it, you will look for it. It's one of the most, I'm sure this country probably has one of the highest prevalence of acid reflux because of all the diet and the food, mashallah, that is available and people eat with lack of exercise. And then we have all those serologies that we are able to do. I'm glad there was an NTLCL 70 case. It was an awesome case yesterday that people are able to diagnose, so great job. And I hope that these antibodies are looked for. the sinus CT, we also look for polyps, and then these are the cases which is nasal potential difference. We look for these and intestine current measurements. They are kind of more research clinical tools for difficult to rule out CF cases. So we are looking for the nasal potential difference because you need two biomarker studies. One could be sweat chloride, the other could be nasal potential, or intestine current measurements. So you do the intestinal biopsy in the lab, look for the chloride conductivity along in those lab models and try to see if we can diagnose CF that way. Therapeutic is one of the very, very newest concept about where you take the tissues to the lab, you actually go to lab, put the drug on that tissue to see the response of the drug in CF, in lab, to see if you can make FDA-approved indication for that drug in lab. Because FDA and the clinical trial may be behind, so they may not have done a clinical trial outside in the world. Given them a pill, it's $1,000 per day. The CFTR modulators that I think somebody was talking to me earlier about, that ivacaftor, and we'll talk about at 5:40 p.m. So that's where $350,000 per year, and we are able to get that through therapeutic for those cases. But that drug has changed the life. These patients used to die, have exacerbations. We are able to just have a huge impact and a game changer. I think bronchiectasis, which is coming in for non-CF, will be having a similar impact, but I think this is one of the game changer drug in CF, the CFTR modulator. And the ciliary biopsy, we also do it for cases with PCD, with the help of ENT mainly. So just to give you some risk stratification, patients there frequently ask us, okay, doc, what's my prognosis? So the answer is look for these tools, either in the computerized apps or do a printout or hard copy. You can look at these if they have Pseudomonas, 3 or more lobes. This is about usually a 9-tool evaluation. This is about a shorter 5-tool evaluation. Gives you some prognosis, how bad their progression of bronchiectasis will be, and you can risk stratify them. The treatment advances, so again, we have modulators and a lot on CF this evening to tell you about all the advancements in CF. The alpha-1 you can augment, so look for these things and able to treat them because you can use biologics, you can use immunoglobulins, you can use alpha-1 augmentation, you can also correct this surgically or medically. For airway clearance devices, I'm sorry to hear that there is really lack of existence of any mechanical device. So I don't know the education there. I'll be curious in this conference for pulmonologists and in the future to see what is the status of airway clearance therapy in Pakistan. That to me is 50% of the treatment of TB, non-TB, bronchiectasis, inhalation physiology. I mean, the physiology taught here is one of the best in the world. Why can't we apply that physiology in clinic and teach these patients about how to improve their peak inspiratory flow, how to improve your peak expiratory flow, increase your exercise, hold your breath, take your progressive breaths and take it out. And it helps the mucus clearance. So I think it's very important to look at these devices. That's about $15,000 to $20,000.
2 minutes left.
Okay. Hopefully, I think 1 or 2 slides. We also have the anti-inflammatory, anti-neutrophilic therapy. This is good for Pseudomonas and non-Pseudomonas. We have inhaled antibiotics. We do all sort of different inhaled antibiotics. 2 or 3 are FDA approved and have a great impact. And then we also treat exacerbations if they have 10% drop in PFT. We do about 14-day course of antibiotic. We monitor their PFT. Important to isolate Pseudomonas and eradicate. That's the message over there. If you have first Pseudomonas before it becomes mucoid, in the lab report it comes as mucoid or non-mucoid. Before it becomes mucoid, you can eradicate. You can save life. You can impact mortality if it is non-mucoid and you're able to eradicate it. So avoid. These are what not to do in these 2024. Not inhale steroids for everyone. No oral antibiotic routine or cycling antibiotics. No oral steroids. And please, no macrolide therapy without ruling out EKG as well as doing some sort of hearing evaluation and looking for the sputum for AV. Those are the cardiac toxicity, hearing toxicity. You can have some hearing loss. I think one of my last slide here, again, we are trying to see can we detect before the CT anything that we can detect before bronchiectasis actually develops and become irreversible. We're also trying to look for how can we better establish the genotypic and phenotypic characteristics by looking some of the genetics and cell models and also looking at whether it's a neutrophilic inflammatory, why certain people are more progressive versus others. And then these are some of the research-based tools that are being used for GM-CSF, sildenafil for ciliary motility agent, the CFTR modulators, looking at the microbiome. There's a concept. If you give antibiotic like anaerobic, you are going to kill GI bugs and going to promote the lung bugs. So we are trying to get away with all these anaerobic killers like Zosyn or Piptaz and Avacaz, Avibactam, those sort of things, which are not just give it out randomly. So please try to look for those things. Again, brensocatib has a huge impact, one of the newer oral therapy for the neutrophil. And, this is the vitamin C inhaled phage, inhaled nitric oxide, and development of registry. Nitric oxide is to kill Pseudomonas. Phage is also attacking Pseudomonas, and then looking for the biologic and the inhaled vitamin C with that. I don't have time for these cases. These are interesting.
Sir, we can have just quick two questions and very quick. Sir, thank you. Sir, please.
First of all, Nauman, thank you very much for coming over here. Bronchiectasis is one of the most mismanaged diseases in Pakistan, and I'm thankful to Dr. He actually was the first one who is a lone tree in the desert, and we have a nascent team, myself included. We're just trying to develop an interest in this. But our main concern is adult bronchiectasis, and more so, I think we need to develop an algorithm based on the people and the disease in Pakistan, and we dearly like your help. How to actually develop an algorithm with the constraints that are available and with the investigations that are available. So a poor man's choice. So we can sit together and develop an algorithm which is applicable to a country which is resource constrained. And we would very much like your help in this regard. Thank you.
Thank you.
One more question, please.
I think this was very helpful, Brigadier Kazmi. That I think I will be all for it. I think this is very important to develop a registry and database and